As you know, probably that particle therapy as a very interesting interdisciplinary field between physics and medical science has been in center of attention for many years. And we are lucky to hear about this fast-growing field from one of the recognized leaders of the particle therapy. Today, we are very honored to have Professor Dr. Marco Durante as our guest speaker to talk about particle therapy for us. Presently, Marco is the director of Biophysics department at GSI. Probably you know that GSI is located in Darmstadt in Germany. He's also a full professor of physics at Technical University of Darmstadt. And at the same time, he is a joint professor of physics at the University of Naples Federico in Italy and the Gunma College of Medicine in Japan. Marco got his PhD in physics in 1992 at the University of Federico and has worked as postdoc at the Lawrence Berkeley Laboratory, NASA Space Center, and NIRS, which is in Chiba, Japan. He is also an active member of many committees that I just mentioned a few of them. Due to the time pressure, in fact, I cannot name all of them. He's currently chair of the ESA Life Science Advisory Group and of the ESA Topical Team on Space Radiation. He's also vice chair of the Particle Therapy Cooperative Group and member of the Technical Scientific Committee of the Italian Hadron Therapy Center. In addition, from 2011 to 2015, he was president of the International Association for Radiation Research as well. He has received many grants to support his research. I just mentioned the very recent one. He has received very prestigious ERC Advanced Grant, which is given by European Research Council. He has also received many awards from well-recognized societies, including Radiation Research Society, United States, Medical Radiological Research Center, Russian Academy of Science, European Radiation Research Society, and European Physical Society. Marco, I thank you on behalf of everyone in this meeting for accepting our invitation. And we are very keen to hear about recent advances in particle therapy. Please.
Thank you very much. I thank you. I thank you for this very nice introduction, and I'm grateful to all the people in the audience. I will indeed talk about particle therapy, and let me try to share my screen. I will share the entire screen, so don't be surprised if you see something odd now. Now, tell me if you see the PowerPoint presentation now.
Yes, we see it. Okay,
good. Okay, great. So thank you again for this nice invitation. And it is actually my first time to speak to the Iranian Physics Society, but I was actually following very closely the progress in particle therapy in Iran, and with great interest because of the plans for building a carbon ion therapy facility in Iran. So I think this topic can be interesting for the Physics Society because in my experience, there is no real possible carbon ion therapy, heavy ion therapy, without a strong support and involvement of the physics community in the country. So that's my personal motivation to accept with great pleasure to speak in this forum, and thank you very much for the invitation. So I will start with the physical advantages of charged particle therapy. I'm talking now in general of charged particle therapy, both proton therapy, which is very common in the world, and carbon ion therapy, which is still a niche with only 12 centers currently active in the world, and 4 in Europe, and 8 in East Asia, 6 in Japan, and 2 in China. So the main advantage from the physics point of view is that thanks to the Bragg peak, thanks to the physics of charged particle, every time you treat a tumor, here we have brain, head and neck, lung, abdominal tumor, pelvic tumor, with particles, here is proton in particular, you will spare a lot of normal tissue. You see, this is what you have to do with photons. You have to irradiate almost the whole brain, of course, this is the tumor, but this is the normal tissue, which is also irradiated. With protons, you can spare a lot of normal tissue. So the main advantage is that you can have the same tumor control with the same toxicity, or you can, with the reduced toxicity, or you can have the same toxicity but increase the dose, so having a better tumor control. Now, the beam delivery system, which is used these days, is based on pencil beam scanning that has been pioneered actually at GSI in my institute. Is based, it's like a TV, you know, you use magnetic deflection on the XY axis and you scan different slices of the tumor, and the movement in depth on the Z axis is due to the energy change. So as I told you before, there are many centers now growing in particle therapy. This is the situation in Europe. We have 30 centers in 2020 active and 16 still under construction. It's a little bit everywhere in Europe, you see. And as I say, there are 4 carbon ion centers, 2 in Germany, 1 in Italy, and 1 in Austria, Med-Ostron in Austria. And I think your center will be in strong connection with the Austrian center with Med-Ostron. Now, what are the advantages of particle therapy? Generally speaking, you have physics advantages that are linked to the physics of charged particles. Of course, the better block formula. I think these are all easy things for physicists. So you have the Bragg peak. So you have the normal tissue here and the tumor tissue here. But for protons, that's it. It's only physics advantages. But for carbon ions or heavy ions in general, you start to have also biological differences that you see in this sketch here. You see that when you have heavy ions, you see when you have fast ions here, which are still similar to X-rays, but when they slow down, if the charge is high enough, they become very densely ionizing. So they induce this kind of clustered DNA damage that you see here, as compared to photons that you see here. So this is, you see the double-strand breaks, DNA lesions in a human cell. If you use X-rays, you will have sparse dots. The breaks are almost uniformly distributed in the cell. But if you use the carbon ions, you will have streaks, as you see here, which means that the cell is the particle is going through the nucleus. So this means that biologically the lesions are different, and you can exploit this biological advantage, unlike proton therapy. So while proton therapy is a technological improvement of photon therapy, carbon ion therapy in general, heavy ion therapy is a breakthrough because you can really use a different biology in the tumor and in the normal tissue. This is probably better shown in videos. So now, if you put the fluorescent microscope and you irradiate the cells, here you see 3 cells. The time is shown here. This is a couple of hours, even more after irradiation. You see that when you irradiate the cells, you form this DNA double-strand breaks that you can visualize with fluorescent microscopy using GFP protein of DNA repair proteins. And you see the uniform distribution of the damage in the cells. But when you use heavy ions, the situation will be different. You see now the streaks, the formation of the streaks in the cells due to the exposure to heavy ions. You see it even better here. You see this is the time. And if you wait for the start, you see this is the start. After about 30, 40 seconds, you start to see a strong fluorescent signal due to the recruitment of DNA repair proteins in the cell. So you see live how is the formation of the damage in the nucleus and how different it is for heavy ions compared. These are 2 streaks, you see. One heavy ion is going here, and one other is going here, and the damage is formed along the streak, and DNA repair proteins are recruited to the sites of DNA damage. And that's also other examples. You see, boom, you see the arrival of the streak of the ions here. And this protein here in particular is involved in single-strand break repair, which means that the signal disappears quite quickly because it's very easy to repair. And again, here at zoom, where you see the formation of the streak in the cells. And if you are familiar with nuclear physics, you see that heavy ions going through here produce delta rays, high energy electrons. These high energy electrons are the range is so far that you see from here, the high energy electrons are inducing DNA double-strand breaks in the neighboring cells. So that's also a characteristic of heavy ions. It's not only the main track, but the damage induced by the delta rays at a certain distance from the site of traversal. Okay, so what is the problem of particle therapy then? Why we don't have particle therapy everywhere? You see that this is a comparison in the cost of the machine. The dose advantage is in an arbitrary scale, the physics advantage, and the RBE, the biological advantage. RBE means relative biological effectiveness. You see that for example, neutrons have a very high RBE, and they have a relatively low cost. They are not very expensive, but they are as bad as photons. This is 3D CRT, this is IMRT, which is a little bit better than 3D CRT, but still in terms of physical dose distribution. While if you go to protons, helium, and carbon ions, they have high biological effectiveness and excellent dose advantage. So why don't we all move to the carbon ions? Because of the cost. You see, just to give you a simple example, IMRT, which is the linear accelerators that are used for producing photons, the standard in normal radiotherapy, the cost is in the order of $5 million. So something comparable to a new flat in Manhattan, in the central area of Manhattan. Proton therapy, you go now in the order of $20–30 million, which is in the order of the cost of a yacht. But for carbon ion therapy, you need something in between $100 and $200 million, which is close to the cost of a Boeing 747. So it's definitely more expensive, let's say. It's definitely more expensive. And the criticism from the medical community is that even though there is this increased cost, there is no level 1 evidence of superiority of carbon ion therapy compared to proton therapy or photon therapy. That's because superiority in medical terms is given by the so-called randomized clinical trial, the phase 3 clinical trials. And at the moment, this evidence is lacking. We don't have randomized clinical trials proving the superiority. Why is that? There are many clinical trials ongoing, many phase 3 clinical trials ongoing, either comparing protons to X-rays, especially in the US, or comparing carbon ions and protons, especially in Germany. But it's difficult. It's difficult to do clinical trials with particles because there are many differences. The physical dose distribution is different. The fractionation scheme is different. And of course, the biological effects is different. So doing clinical trials is not easy. And an example of how difficult is this is a clinical trial that was very much advertised. It's a clinical trial of protons versus photons versus IMRT for lung cancer, where the primary endpoint was this was a clinical trial from MD Anderson, which is probably the most famous cancer hospital in the world. They have protons since many years. The clinical trial, the primary endpoint was toxicity, was pneumonitis induced by radiation. And the idea was that at the same tumor control, you should get lower toxicity with protons. Now, you see that in fact the survival, this is the survival of the patients, is approximately the same if you compare IMRT, X-rays, and protons. There is no significant difference. But with some surprise, if you look at toxicity, toxicity was essentially, there was no statistical significant difference in toxicity. Actually, if you look at the number, protons had slightly higher toxicity, but fortunately, grade 5 toxicity, which is the worst, means death of the patient, was only with X-rays and not with the protons. But still, you see, it was not statistically significant difference. So why is that? That's a little bit strange, because if you look at the dose volume histogram, so that's the dose, and this is the relative volume of the lung receiving that dose, you clearly see that for X-rays, you have this region, a lot of volume of the lung receiving a low dose. At high doses, of course, it's the same, because it's really the target region, but in the low dose region, you spare a lot of lung. So why this had no effect in the clinical environment? This is an interesting question. So we decided to take the treatment plans of the patients and to do a voxel-based analysis of the differences for patients having radiation pneumonitis of grade greater than 1. And what we found, you see here, that the difference in patients developing pneumonitis and those that did not develop pneumonitis was the dose in the lower part of the lung and the heart. So that's the important site, anatomical site, for developing radiation-induced pneumonitis. But when we went to compare the patients receiving X-rays and the patient receiving protons, we found out that most of the difference you see here was in the upper part of the lung. So there was an advantage in proton therapy because the upper part of the lung received a much lower dose, but this advantage was not in the right volume. And that's why you see no difference in toxicity. So you see how difficult it is to do clinical trials, to prove the superiority with clinical trials, because you see, in this case, with the careful voxel-based analysis, you could have predicted that no difference was expected. So somehow our research is lost in translation. I don't know if you are familiar with this beautiful movie of a few years ago with Scarlett Johansson and Bill Murray. It's lost in translation. We work on the bench, but we don't communicate effectively to the medical doctors to improve the quality of the treatment for the patients, which is actually what we really want. What can we do? I mean, one thing that we should work on, for example, is hypoxia. I mean, notoriously, heavy ions are more effective than photons for hypoxic tumors. Hypoxic means that there's not enough oxygen, and this makes the tumors more radioresistant. The so-called oxygen enhancement ratio can be as high as 3. This means that the hypoxic tumor will be 3 times more radioresistant than the oxic tumors. But this can be smashed, you see, using heavy ions. You see that if you plot the OER as a function of the LET, the OER goes down for every oxygen concentration, goes down at high LET, actually a fairly high LET, you see here, meaning that heavy ions should be elective for treatment of hypoxic tumors. Which hypoxic tumors we know? For example, one tumor that we know since many years, this is a paper from MD Anderson 20 years ago, is that pancreas is a very hypoxic tumor. You see this for different patients, they measured the median PO2 and the fraction of the tissue with less than 2.5%. And you see that all the tumors were very hypoxic compared to the normal tissue. So pancreas is a very hypoxic tumor, and pancreas is a very deadly tumor. This is now the 5th cause of death among the different tumors in Europe, even though the incidence of pancreas cancer is relatively low, but the mortality is the same as incidence. You see that we can treat, this is a slide I got from Japan, where for the treatment planning of pancreas cancer is very complicated because the pancreas cancer is surrounded by organs at risk, you know, like stomach, duodenum, and spinal cord. So when you do an X-ray treatment, you cannot increase too much the dose because then you will give unacceptable doses to these critical organs. But the results, this is the result of a phase 2 clinical trial in Japan, is a multi-center clinical trial involving NIRS, GUMMA, and Saga HIMAT. The results are really amazing because you see the survival at 2 years is about 60%, while with conventional radiotherapy, the survival at 2 years is less than 10%. So even though this is not a comparative trial, it shows that the improvement that you can get with carbon ions for pancreas cancer is extremely high. Now, this is an example, but the other big question that now we have is whether we will need radiotherapy at all in the future. Why is that? Because if you go to an oncology meeting these years, they will tell you that this is the cover of the Science magazine in 2013, that cancer immunotherapy is the key to solve the cancer problem. And where now the Nobel Prize for Medicine in 2019 were given to Alveston and to the Japanese that found these checkpoint inhibitors that allow immunotherapy of cancer. The results are really amazing. This is the example of, this is a melanoma, malignant melanoma. You see, this is a PET CT image of a patient with multiple metastases everywhere in the body. You see, this was done in April, and then if you take the same patient in August, after treatment with immunotherapy, all the metastases are gone. So melanoma is a very immunogenic tumor. The results are very good. Unfortunately, they are not this good also with other tumors. And even with melanoma, you see the red curve shows the survival of patients treated with the ipilimumab, the drug that I've shown you before, is about 20%. So this means that 80% of the patients are not responding. But this is getting better. You see, we're using a combination of different drugs, of different immunotherapy cocktail. For melanoma, they went up to 50%. Situation is not this good with other tumors, so the idea is that combination with chemotherapy, targeted therapy, or radiotherapy can raise the bar, can improve the survival of the patient. Why radiotherapy? Radiotherapy because radiotherapy itself can induce immune stimulation, because when the cells die after a high dose of radiotherapy, the cells die and they release immunogenic factors like ATP and HMGB1, and this immunogenic factor can stimulate dendritic cells to produce cytotoxic lymphocytes that eventually can attack the tumors everywhere in the body. But radiation also elicits immune suppressive signals. And these immune suppressive signals that are shown here block the activation of the dendritic cells. So if we can use immunotherapy to suppress these signals, then radiation itself will work as a vaccine against your own cancer. And this has been exploited now. This is a clinical trial recently published in Nature Medicine by Weil Cornell. It's a combination of, in lung cancer patients, a combination of radiation to a single metastasis and immunotherapy in patients that were resistant to both radiation alone and immunotherapy alone. This is a trial of the combination. And you see that actually turns out that about 30% of the patients responded positively to this combination. So the big question then is that if this is the direction, if we are moving toward particle therapy, radiotherapy plus immunotherapy, and X-rays is so cheap, So can particle therapy do better? This is now going to be the real big question in the scientific community. And this is a paper that I published with David Brenner and Silvia Formenti, who is a great expert in immunotherapy, a few years ago. First of all, there are trials ongoing. This is again from Japan. It's a treatment of a pancreatic tumor where in combination with immunotherapy, and you see that the lung metastasis disappeared with the combined treatment. But the question is why? What can be the advantage? Well, one advantage is certainly linked to the physics itself, because as you have seen at the beginning, if you use particle therapy, you spare more normal tissue. This means that you spare more lymphocytes that are the cells that you need to elicit an immune response. So if you kill these cells with chemotherapy or with radiotherapy, you will not have an immune response. But you see, if you compare the chromosomal aberrations in lymphocytes, the damage in lymphocytes for X-rays and carbon ion patients, you see that it's higher X-ray patient than in carbon ion patient, which is somehow surprising because, you know, if you do the experiment in vitro, you will find the opposite. But in vivo, you find this situation because you spare a lot of normal tissue, thanks to the physics of carbon ions. And this is also seen in lymphopenia. You see, if you look at the loss of lymphocytes, this is a recent paper from the MD Anderson comparing photon patients and proton patients. You see a large scatter, but proton patients have less lymphopenia in esophageal cancer patients. And this was also found many years ago in an experiment in Japan, showing that, you see, the level for carbon ions remains constant. You don't lose lymphocytes, but for patients with X-rays, you have a trend. For all of them, you have a trend to a decrease in the number of lymphocytes. But there are also biological reasons. You see, this is a very recent experiment that we published together with our Japanese colleagues, showing that if you compare the lung metastasis in mouse after irradiation with X-rays or carbon ions, you see that this is the control metastasis in this is an osteosarcoma model that gives lung metastasis in the control. Now, if you treat here carbon ion plus checkpoint inhibitors, CPI, you essentially delete all the metastasis. Well, you see X-ray alone are not very effective, and X-ray plus checkpoint inhibitors are also effective, but not as much as carbon ions. So this will be certainly one of the main topics of research, but I want to conclude my talk with some more futuristic view linked to the physics innovation. The physics innovation is also related to the new accelerators under construction. I mean, this is the place where I work, GSI, and this is what we expected to see in 2025 when FAIR, the new accelerator, will be completed. So this is the old accelerator here, and now this will become the injector of the new accelerator here. Now, this is called FAIR. FAIR has already started, even though the accelerator is not ready. There has been an energy upgrade here. It's called FAIR Phase 0. And there are many new accelerators under construction in Russia, in Korea, this is ELI, is a laser in Eastern Europe. SPES is in Italy, Spiral 2 is in France, FRIB is in the United States. There are many new accelerators that have new possibilities that could be interesting for biomedical research. That's why we had a very nice meeting of the International Biophysics Collaboration at GSI. This is obviously a pre-COVID-19 meeting. You see many people packed together without masks. It was 250 participants from 27 countries in all 5 continents, so it was certainly a big success. And the main conclusion, which you can find a publication here, the Frontiers in Physics, is an open access paper, so you are invited to read it, is that if this is the range of the current accelerators, you see, in intensity and energy, You can do a lot of radiation protection studies, you can do carbon ion therapy, you can do some space radiation research, but if you increase the energy, you can do, for example, better space radiation research, but also particle radiography, because we have particles that go through the patient. And if you increase the intensity, you can do beautiful things like microbeam radiation therapy, flash radiotherapy, and radioactive ion beam therapy. I will spend a few words on this application of high-intensity accelerators. First with flash. Flash, you probably have heard of it because it's a big hype. Originally comes from France, where they found out that if you irradiate at very high intensity, 40 gray per second or more, you can have the same cure of the tumor, but sparing of the normal tissue. This has been seen, it's been applied already in patients. You see, this is a paper where there was a treatment of patients. Of course, it is very difficult to have a flash intensity with photons, because the photons are produced by Bremsstrahlung of electrons, and the conversion of in the Bremsstrahlung efficiency is quite low. So this is done with electrons. You can do it with protons, and it will be, there are clinical trials already ongoing with protons. The idea, the reason why apparently there is this this effect is due to the oxygen depletion hypothesis. So this means that, you see, for normal tissue, the oxygen depletion makes the tumor, the normal tissue radioresistant, so hypoxia again, while for the tumor, which is already hypoxic, there is no change. But this depends very much on many physical factors, you know, like the dose per pulse, the pulse duration, the dose rate within the pulse. There are many physical factors involved. We have recently, you can see it here, you have seen this flash here. It's a real flash. You see it again here on the top. We have recently proven that you can do flash also with the heavy ions, with carbon ions in particular. We reached the, you see, this is the GAF chromic film, and this is our setup at GSI. We delivered 14 gray that you have seen here in a time of 200, you see 13.4 gray to be precise. I mean, this is the real measurement in a bunch of 200 milliseconds. So this is a proof of principle that flash radiotherapy can be done. So we will test it. We will test. Excuse me. We will test the flash radiotherapy with carbon ions in an animal model in the upcoming beam time in 2021. And it will be very interesting to see whether flash can be used for carbon ions. It's not only the biological advantage, as you can imagine, but also it will be very convenient, because if you can really give if you can really make your irradiation so quickly, you don't have to worry about moving targets, you know, because you actually irradiate in a flash, and also the treatment will be extremely short. So it's a big advantage for everything. Microbeam radiotherapy also needs a high intensity. What is the idea here? The idea is that if instead of irradiating with a broad beam, you make a spatial fractionation, like you can do with this also with X-rays, using synchrotron radiation or using special collimators, then the normal tissue will be very much spared. Now, you have to do it. This has been done with protons. It's been done with protons. This is an example. You see a spatially fractionated treatment with protons, and they have found reduction of skin toxicity, reduction of neurotoxicity, and increased therapeutic index in glioma bearing rats. Now, the idea is that if this is really a way to spare the normal tissue, can we do it with heavy ions? Because one of the reasons we use carbon ions, we don't go to heavier ions, is toxicity. If you use heavier ions, like it was done in Berkeley many years ago, you can have toxicity. But if microbeam can spare the normal tissue, then maybe we can use argon. We can use some heavier ion that would be extremely more effective for very radioresistant tumors. So that's what we will also test now. You need a high intensity because you have to make sure that the movement of the patient is not compromising this pattern of spatial distribution. But we will do it in next year. We will try in an animal model the microbeam with very heavy ions in collaboration with the CNRS in France. And finally, one of the main technical problems in radiotherapy is the range uncertainty. The problem of the range uncertainty, you see here, this is the depth dose distribution for X-rays. And you see that if there is a shift in the depth dose distribution, for example, due to different densities through the tissue, this has a very small effect on the dose on the tumor. But if there is a shift in the Bragg peak, then this is quite a big problem. You see it here again, what happens if you have tumor shrinkage during the treatment. You see, if your tumor, which happens with carbon ion, shrinks, and you don't change your treatment plan, you will go into this situation, you know, where now the beam is going on the other side and hitting the esophagus and the normal tissue behind. This is a lung tumor behind this tumor. So the problems of range uncertainty are tumor shrinkage for sure, but also the CT number to spotting power conversion. You know, we make the treatment plan on CT scans that are done with X-rays, but then we have to convert the Hounsfield units into water equivalent path length. And this is an uncertainty. And then, of course, the organ motion, the motion of the organs, respiration, rectum gas, bladder filling, all of them can change the range. So how do we deal with this range uncertainty? That the problem is that at the moment you deal it enlarging the margins, which is bad because eventually you irradiate a lot of normal tissue and you lose the nice specificity and precision of particle therapy. You see, this enhancement of the margin, there is a nice example based on the orange skin. Even if you add a little bit of margin to the tumor, this is like having the skin of the orange. If you take the volume of the skin of the orange, this is almost as big as the volume of the orange itself. So the adding margin means that you have a substantial volume of normal tissue which is exposed and could be not exposed. So what we have proposed is to use radioactive ion beams, which can be produced if you have high intensity via in-flight fragmentation. And radioactive ion beams like carbon-11 or carbon-10, they are beta plus, they decay beta plus in positron. So you can visualize the beam using PET, positron emission tomography, which is normally used in diagnostics. This can be done also with carbon-12, but you see, the problem with carbon-12 is that the peak of the activity will not be corresponding to the peak to the Bragg peak, let's say. And also the signal is very weak. This is the signal after 20 seconds and after 20 minutes. If you use carbon-11, you see that now Bragg peak and activity peak stay together, and also the signal-to-noise ratio is incredibly better. And same if you use carbon-10. Carbon-10 has such a short half-life, only 20 seconds, that you can actually visualize the image really online during the treatment. This is the plan that we have in this ERC project that was mentioned in the introduction, this European Research Council project to use radioactive ion beams and an innovative detector to visualize the beam and eventually to treat for the first time to have an animal patient treated with carbon ions. You will find more details at this webpage. So, in conclusion, this is my conclusion. I want to thank you again, and I want to show you the picture. This is our webpage, and this is the picture of my group, which is a very big group. It's about 80 people now, about 50% physicists and 50% biologists. So it's a very interdisciplinary group. And we are very open to all kinds of collaborations, and we look forward very much to the programs in Iran, and we hope that you will pursue this heavy ion therapy that, as I showed you, I mean, is convenient for the patient and is also an important research topic with a lot of potential for improvement. And again, thank you all for your attention, and I'll be happy to take any questions.
Okay, thank you, Marco. Now we have plenty of time for questions and answers, probably.
Yes.
Yeah. If you have questions, you may raise your hands or probably type in the box below, and then we will ask our speaker to answer the question. Probably I should take advantage of this time and ask a question. Probably some questions are triggered then. You are talking about radiotherapy using beams of the size of micrometers and things like that. Does that mean that the main challenge in future would be aiming and calculating and monitoring the position of tumor itself?
Yes, this is a good question, because the problem, as you have realized, is not only the delivery of the beam, but where is the tumor? This is a very good point. Even if you go to flash, to very high intensity, you still have to know in that milliseconds where is the tumor. So monitoring the movement is extremely important. You can do radioactive ion beams to monitor the beam, but you still have to know where is the tumor. So the visualization online of the tumor can be done with fluoroscopy, which is X-ray imaging, can be done with ultrasounds in principle, if the tumor is moving. But it's certainly one topic where the imaging sector must be entangled to the radiotherapy sector, because we definitely need an improvement. In the X-ray world, now there has been a very recent breakthrough in this topic, which is the MRI LINAC. So the LINAC used for X-ray delivery has been coupled with the magnetic resonance, so you can actually see the movement of the patient and follow the movement of the patient with the X-ray beam. That's also a possibility with the particles. Of course, you have to take into account this magnetic field that will give you some deflection of the beam, but you can calculate it, of course.
Okay, and that means that the cost of treatment will be quite high then?
The cost of treatment is still high, unfortunately. I mean, it's still much higher than for photons. We have to admit it. The introduction of MRI LINAC in the conventional radiotherapy also has increased the cost, but now MRI LINAC are in many centers. So I'm not so worried about the additional cost. I'm much more worried about the gap between photon therapy and heavy ion therapy, and you need to demonstrate that you have a clinical advantage. That's where we should really focus, because of course, if you take a tumor like pancreas and you look at the Japanese results compared to the US or Europe results, you will say that definitely, even if it is much more expensive, there is such a big advantage that you want to go for it. That's what we need. I mean, we need to show that, and that's where research is really needed. We need to show that the research is cost-effective. The treatment is cost-effective.
Yeah. Okay. I still do not see any questions. Probably I should go for second question and then. On the map that you showed in the beginning of your talk, we realized that England is one of the, I guess it's the only country which joined this club quite lately, I would say.
That's correct, but very enthusiastically. I don't know if you see the slide now.
No, I don't see it now.
Oh, you don't?
No, I don't see the...
Yeah, because I stopped sharing. Sorry, I have to resume sharing. You mean this slide here?
Yes, yes.
You're right. United Kingdom joined late, but very enthusiastically. There is now 7 centers in United Kingdom. Seven, and they will build like in 5 years. 5 of them are private. They are small, single gantry, single room centers, and 2 of them are public. One is the UCL, University College London. Still has not started, but it will. And the other one instead started already a couple of years ago. It's in Christie in Manchester.
I see.
I think one of the reasons why UK was so late to enter in the business is that they had a very bad experience with neutron therapy in the past. Neutron therapy was pioneered in UK, but the toxicity was very high. So many patients had severe toxicities after neutron therapy. And then somehow the radiation oncologists in UK were scared of particles. You know, they were making kind of confusion between neutron, protons, heavy ions. They say these are all particles, they are all bad, you know. So it took some time, you know, to get them to accept the idea that protons are not neutrons and they don't have to worry about. But now UK is a very prominent country in particle therapy in Europe.
I see. No, I see that 2 questions came up, but I prefer to go on with a follow-up question. The fact that the United Kingdom joined the club quite lately does not have anything to do with the cost and things like that. No?
Not really. It's not the cost. The problem was really the bad experience that they had with the neutrons. And the cultural risk is a little bit the same story in the United States for carbon ions. You know, United States have a lot of 20 centers of proton therapy, but so far not a single center with carbon ions. And the reason again is that they were the first to do heavy ion therapy in Berkeley in the 70s, so like 50 years ago. But at that time they had some bad experience, and they are still, you know, the radiation oncologists are still very skeptical. Even though now it has been officially announced that Mayo Clinics is one of the most important medical centers in the US, will build the carbon ion center in US. So, but again, it's more a historical reason than the real economical reason.
I see. Okay. Now, Dr. Hassani, you may ask your question, and then afterwards I will read Dr. Nahal's question. Yes, please.
Thank you very much for your informative talk. I was going to ask you, can you compare this ion or heavy ion therapy method with things like drug delivery techniques, which are very, I don't know if people say that they are very optimistic techniques. I don't know if they can compare it with this ion therapy techniques. Can you explain about that?
Sorry, I missed one word. I mean, if I can compare heavy ions to which technique?
Drug delivery techniques. Where people, you know, guide small drugs to the
targeted therapy. Yes, targeted therapy. Yes. So the targeted therapy, as I show one slide where I was talking about chemotherapy, targeted therapy, and immunotherapy. Targeted therapy is very interesting, but so far the clinical output of targeted therapy have not been so diffused. Maybe you refer to the alpha particle immunotherapy. I mean, if you combine an antibody with an alpha particle emitter, then you can target the tumor. That's very interesting, but you have to be sure that this is very specific, so that you are actually targeting that very tumor. And at the moment, we don't have enough experience to say that we can be successful with that. There has been a trial in metastatic prostate cancer with astatine 211, which is an alpha particle emitter, that gave very, very exciting results. One other problem there, again, is that is the production of these alpha particle emitters, because, of course, as you know, to produce alpha particle emitters, you need accelerators and high intensity, and then you need chemical labs to isolate them. So it's a bit complicated, but it's definitely promising. I think it's less mature than teletherapy, let's say, that external beam therapy, but it's very promising too.
Thank you very much.
Okay, Marco, there is a question typed in the chat box below. I don't know if you see it. If you scroll up, you see.
At the moment, oh yeah, this is in English. I see that. So how do you the diffusion depth of your beam? What is the mechanism? So yeah, I'm sorry. Maybe in the movie, this movie here, I wasn't clear enough. This was the movie. Now, if you look at the movie, you see the XY movement, right? And this is only magnets. It's a XY. It's a scanning magnet. So it's an XY magnet deflection. To move in the depth position, you just have to change the energy. So you see, if you have high energy, you are deep in the tumor, and then if you reduce the energy, you go to the proximal edge of the tumor. So it's rapid energy changing in the synchrotron linked to these magnets here, these scanning magnets that can deflect the beam on the X-ray axis.
Good. I see no further questions. Let's thank our speaker again and move to the next session. Marco, thank you for accepting our invitation.
Thank you very much.
I hope that we can have you for our next meetings. Thank you.
Hope so, live.
Yeah, thank you.
Thank you very much. Bye-bye.